Hi all, Dr. H here, your source of musculoskeletal care, and this is going to be part 2 of our postural series. Here we're going to dive into the most common postural issues I see in the upper body, especially in the shoulders, and how to correct them. Honestly, I've had patients get relief for issues in their arms, neck, shoulder impingements just by making a few of these modifications and with no other interventions. So if you're someone who has weird nerve pains in your arm, pain in what we call the posterior neck angle back here, shoulder impingement issues, anything like that, then you might find benefit from this video. So let's talk about all that. So the main myth I want to address in this video that we talked about in the last video is this idea that you need to posture your shoulders back and down, or what we call scapular retraction and depression. And the truth is that this is rarely appropriate for today's patients. Today's patients and the more common postural issues I see in today's patients make this recommendation of back and down not only unhelpful, but sometimes even injurious. Now, I will say that when I was looking up more data for these videos, I was actually very pleasantly surprised to see how many resources out there were dispelling this myth of back and down and recommending that you don't do it. Unfortunately, this is still grossly outweighed by all the recommendations and videos on the internet and what people are just being told by whoever. Still, I will say that if you're working with a trainer or seeing a musculoskeletal clinician or just following someone's advice online, this can be a good litmus test to see if they're aware that this back and down patterning of posture is not advisable. And if they are aware of that, then it's a pretty good indication that their knowledge is a bit more up to date. So why is back and down such a bad thing? Why are we making an entire video kind of addressing this point? Well, here we kind of need to get a little bit deep into the weeds of anatomy. The shoulder is a very complex joint. I have a model of it here that we'll be referring back to a few times, but for the most part it's made up of your collarbone or your clavicle, your arm bone, your humerus, and the shoulder blade here, or your scapula. And then there's a lot of soft tissue components in between. In fact, the shoulder is mostly held together at the joint here by soft tissue, things like your rotator cuff and other soft tissue components. In this way, the shoulder, unlike the hip, isn't really a true ball and socket joint. It's more the ball is being held on to the shallow socket by soft things. And because of this, it has a great range of mobility. However, it has this by sacrificing stability. And because it has all this mobility, it has a little bit more potential for things to go wrong. To add to the complexity of the joint itself, you actually have a rather intricate neurovascular bundle. So it's a combination of nerves and vessels that travel underneath your collarbone and above your very first rib. And then they usually go to supply the rest of the arm, with some exceptions going to supply parts of your back. Well, the one thing I want you to notice here is that your collarbone is pretty firmly connected to the shoulder blade. But there's no first rib in this model. And while the first rib has some soft tissue attachments that we won't get into here, for the most part you can consider the first rib as not being attached to the shoulder blade. So you can imagine that if the shoulder blade goes down, right, that's that back and down. So it comes back towards the ribs and then down onto the ribs. You're actually lowering the collarbone with it, but you're not lowering the first rib with it. And like I said, you have a complex neurovascular bundle that is sandwiched between the two. And so what happens with this back and down motion is that you risk putting increased pressure onto the nerves and the vasculature in this area here. So in the most severe forms of this compression, we have names for it, like we do for most severe problems. We call it costoclavicular syndrome, or sometimes you'll hear it called neurogenic thoracic outlet syndrome. But even for people who don't have that severe level of compression, any compression into this area could cause symptoms. There's a phenomenon known as multiple cross syndrome. And this is where you can have areas of nerves, for example, that are being compressed at multiple sites. And while any one of those compressions probably wouldn't be noticeable as symptoms, the accumulation of those compressions is what gives you those weird numbness, tingling, or other nerve issues, or sometimes just pain issues or weakness issues throughout the upper extremity. So in my clinic, I see quite a few patients that have something we call brachial plexopathy, or just injury to this bundle of nerves here that we call the brachial plexus. And almost every single time, there's some degree of compression happening at the shoulder area because of the shoulder blades being too low on the body and too far back and compressing down to that neurovascular bundle. So how do we know for sure that this posturing, this back and down movement, isn't great for that brachial plexus nerve bundle? Well, interestingly, it's what we do as a clinical evaluation when we're testing for brachial plexus compression. We have patients go back and down with their shoulders into this sort of military-based posture, and we see if that flares their symptoms because we know we're increasing pressure on that brachial plexus. In fact, if you look at this rather old study right here, this shows examples of Air Force cadets in the military who had suffered some degree of brachial plexus injury from this military posturing, which is mainly this back and down position of the shoulders. So why is this myth of back and down, of people needing to have their shoulders back and down, still so pervasive? Well, I think that's because if you look around at people, it does look like their shoulders are kind of up by their ears. And so it kind of makes sense that you'd want to pull the shoulders away from their ears. But thinking the shoulders are up at the ears because they're too elevated and forward, or what we call protracted, is a misevaluation. In reality, the problem that most people have, posturally speaking, for their shoulder blades, is that their shoulder blades are riding up and over like this, kind of coming in what we would call an anterior tilt. And because it has to kind of come up and over the thorax, it looks like it's going straight up, but it's not. It's just tilting forward like this. And in fact, if you take that tilt out and let that shoulder ride the thorax back into what we call a posterior tilt, or back to where it should go, now if you look at it, it will actually sit too low in most people. So again, when the shoulder blades ride up and over like this, it looks like someone may have elevated and protracted. Right? The end posture looks very similar, but the mechanism of how the shoulders got there is different, and that makes all the difference. And this is usually accompanied by another postural issue called an anterior head carriage, or when your head sort of hinges forward from where the neck and shoulders meet. So what happens if you combine those two postural issues? You bring the shoulders tilted forward like this, and then the head protrudes forward. Well, now it looks like my shoulders are all hunched up by my ears. And again, this is why I think this myth has continued to be so pervasive. A lot of people have this appearance of the shoulders kind of like this and the head like this, and so the ears and the shoulder are very close together. But again, it's very, very important to understand the mechanism of how they got there. It's not that their shoulders are too high up by their ears. It's that their ears came down to their shoulders, and the shoulders tilted forward toward the ears. And so to correct that will take different cues and different behavioral modifications than what you would get by just pulling them straight back and then down. All right, so if the answer isn't to pull your shoulders into retraction and depression, what is the answer? Well, it's to reverse the mechanism of how they got to where they are in the first place. So as I talked about before, the shoulder is sort of riding up and over the thorax, or what we call an anterior tilt. You look at the model, and again, you pretend the thorax is here, it's riding up like this. So you have to then bring it back into what we would call a posterior tilt. This is not the same as pulling the shoulder blade back into retraction. This has to occur in a plane that is perpendicular to the body, or what we call the sagittal plane. If I turn to the side here, and I put my shoulder into this incorrect posturing, what needs to happen is the shoulder needs to tilt back like this. That is not pulled back, but tilted back. You can see I'm kind of using my arm, and this is actually how I'll cue my patients in the beginning, to use the whole arm in this sagittal plane to tilt the shoulder back, and then keep the shoulder blade there as they bring their arm back down, not letting it come back forward. So this can be a hard maneuver for people to get, and sometimes there are anatomical limitations to doing it. The most common thing I see in my clinic is the joint capsule of the shoulder here being too tight in the back. And when it's tight in the back, it does not allow the head of the humerus here to slide back with it. So we have to do things to work on that, and we usually get that resolved pretty quickly. So once this pesky anterior tilt is out of the way, the next thing we have to evaluate is the height of the shoulder blade. Like I talked about a little bit ago, when you get this sort of up and over out of a person's body, what you'll usually be left with is shoulder blades that actually sit too low. And again, sitting too low brings that collarbone down and risks compressing into this neurovascular bundle. It also pulls on the muscles that go from the shoulder blade to the neck and can cause issues like lower neck pain in that area. So generally speaking, in most people, you're going to want this upper part of the shoulder blade here to be in a straight line with your second thoracic vertebra. So if we look at this image down here below, you can see they have a dot over here labeled SAS, and that is lower than the dot they have in the middle of the spine, I guess would be over here, labeled ST2. So that's that second thoracic vertebra, that's that corner here, and you can see in this image that it's just too low, and that is very common for patients that I see in my clinic. My clinic is self-selecting. The people who come to see me are people who have issues. So I'm not saying this is common for the general population or that you necessarily need to worry about your shoulder blades being too low. I'm just saying in people who do have shoulder issues or neck issues or arm issues, this is a very common finding. If you are someone who thinks their shoulder blade is too low, not only do you have to get that up and over out, but you're going to have to actually elevate the shoulder ever so slightly. Lift that shoulder blade up, almost like into a very, very tiny, you're shrugging like, oh, I don't know, just a very small shrug like that. Now again, you may not be a person who needs to do this, but if you are someone who has shoulder blades that are too low, you are going to have to take that anterior tilt and a slight elevation. That needs to be the posture that you hold on a day-to-day, hour-by-hour basis. Lastly, but very importantly, we need to talk about rotation of the shoulder blade. So if we go back to this model here, and this is the back of the person, you want this outer bit of shoulder blade to be at least at the same level as this inner bit of shoulder blade. If this outer bit is below this inner bit, we call that downward rotation, and we don't want that, and I'll show you why. So if we take a piece of paper here, this is going to represent some soft tissue component of the shoulder, in this case, part of your rotator cuff. And what you'll see is as the arm goes up and out to the side, or if it were to go up and forward like this, so what we would call abduction, bringing the arm out, or forward flexion, bringing the arm up. If the shoulder blade stays still, and this keeps going up, you pinch that paper between the two bones, so between this bony part of the shoulder blade and this head of the humerus here. So what has to happen, and what does happen in a healthy shoulder, is as this arm starts to come up, the shoulder blade rotates up with it and maintains that space. And it does that throughout the whole motion. Well, if you're starting with the shoulder blade already rotated downward a little bit like this, the odds that it's going to rotate upward adequately during this movement of abduction or forward flexion is pretty low. So this lack of ability for the shoulder blade to upwardly rotate during movement is probably one of the most common causes I see of impingement syndrome of the rotator cuff or other soft tissue structures, and is probably a major contributor to eventual wear and tear of rotator cuffs. So I oftentimes have to retrain patients on how to first statically bring this shoulder blade into a little upward rotation, just sitting there, the ability to kind of bring this outer part a little higher than the inner part. That's the easy component. The difficult component is you have to maintain that external rotation, continue to rotate that shoulder blade up as your arm comes up. And usually that takes a little bit of practice to get down. And then we get to the hardest part. When people bring their arm down, they tend to do so by kind of just relaxing everything. Well, the problem is if you finally do all this hard work and you're able to rotate this up, and then the arm can come up here with it, but then you relax to bring the arm down, this shoulder blade has a tendency to want to drop first. So what you have to do is not only train yourself to rotate the shoulder blade up first as the arm comes up, but then it has to stay up as the arm begins to come back down, at least until it gets past that shoulder level, and then it can start coming down with the arm. Again, this can be a very tricky and complex thing to train for patients, but doing so can really help relieve a lot of rotator cuff or impingement issues. And so getting down this shoulder rotation component, the shoulder blade rotation component, can be very difficult to train. And honestly, it's made harder by the fact that people are often getting prescribed exercises that are meant to fix the problem, but may actually be ending up making things worse. For example, there's an exercise known as a wall push-up or a push-up plus, where you're kind of essentially doing like it says, you push up on a wall, and then oftentimes you continue to push forward. And this exercise has been shown in research to be really, really good at targeting a particular muscle. It lives right inside here, called the serratus anterior. This is important because the serratus anterior muscle is probably the key muscle that upwardly rotates that shoulder blade the way we want it to. But what's the problem? The problem you should remember from the first video is that just adding strength to a muscle, even if it's a key muscle in proper postural mechanics, does not magically fix the posture. And in fact, if you look at this study down here, the position that people have to put themselves in to do this exercise, even if they have a healthy non-impinged shoulder, puts them into a posture of impingement. So generally speaking, despite the fact that this exercise is really good at targeting very specifically this one muscle, in the grand scheme of things, it's actually going to worsen an impingement issue in a healthy shoulder, let alone in someone who already has problems in that shoulder joint. A similar and probably honestly even more common problem that I see is patients doing a lot of prescribed pulling type exercises or rowing type exercises. Again, these exercises in and of themselves are great. They target those muscles in the back that most of us need to strengthen. But again, don't fall into the fallacy that just because you strengthen up a muscle, you're going to automatically fix a postural issue. And again, if you do this exercise incorrectly or if it's taught to you incorrectly, you can end up making the problem worse. All right, so I turn to the side here so you can see better. But if I'm doing a pulling motion to target, the muscles in my back, like my traps, as I pull back and I get to about here, everything is fine. My traps are engaged. I've ended my extension of my shoulder. The problem is a lot of people are taught, or just intrinsically do this, to pull all the way to their chest or to their belly or what have you. Watch what happens to my shoulder as I continue to pull. If I go from here and keep pulling, do you see that up and over that we talked about in the beginning of this video? The exact thing we're trying to get rid of. So continually doing pulling exercises to a point where you're getting that up and over rotation is ultimately going to just increase or worsen that impingement. Okay, so this was a very detailed video. I just want to go into a brief summary of how to properly posture your shoulders. One, most of us need to tilt our shoulders back into a posterior tilt. It can be a tricky thing to learn, but once you're able to get it, it'll become second nature very quickly. Some of us, not all of us, then need to slightly elevate the shoulders if our shoulder blades have a tendency to sit too low. If you have a very long neck, or if you look in the mirror and there's a very steep slope from here to here, then you're probably one of these individuals that needs to slightly elevate the shoulders. And lastly, if you have any kind of rotator cuff or impingement issues, you need to practice that upward rotation of the shoulder blade prior to moving your arms and to maintain it as the arms start to come back down to relieve any source of impingement. So this video is by no means an end-all be-all for all the shoulder mechanics. The amount of detail and case-by-case examples that we would have to go to would be very overwhelming to make a complete picture of shoulder posturing. And honestly, it probably wouldn't be relevant to the majority of you. This is where having a musculoskeletal physician as part of your healthcare team can be really helpful, because they can usually evaluate you and make individualized adjustments for your particular needs. But hopefully the things that we talked about in this video will at least start you kind of on that right track. So mind your shoulder posturing and keep moving.